Welcome everybody, and hope you're all having a wonderful Festival of Lights, Hanukkah Sameach, to everybody who's joining us. And we are just getting our tech ready to go and getting our logins all set. So if you'll bear with us for the next minute or two, we are joining together with some of our friends from JFF and along with my newest wonderful partner, Dr. Michael Awadalla. All right, well, I think we have everybody we need who has joined us, and I'm going to take a quick nod from Anna there, and if she gives me the nod on Zoom here, I think we're ready to go.
I think you might have to accept the join request. Did you request to join, Dr. Awadalla?
All right, working on our tech aspects. Let's see if this brings Dr. Awadalla into the fold for us here. And we appreciate everybody's patience while we get all of our tech things ironed out. When they were rededicating the second temple, they didn't have to worry so much about Zoom. So, all right. Well, I think we've got a thumbs up here and we're ready to get going. So welcome. Thank you for joining us this evening. I'm Dr. Michael Scheiber from the Institute for Reproductive Health. Hanukkah Sameach for all you celebrating. We're glad you could join us this evening and hope you get back to lighting some festival lights here before long. I am privileged to be working with our colleagues at JFF as well as my colleagues at the Institute for Reproductive Health, to help us build families here in the Cincinnati community. And we are going to have our guest is our newest partner at IRH, Dr. Michael Awadalla, who joined us this July and is doing a fantastic job with us, who's going to also discuss expanded carrier screening, which is one of the very important, very critical areas in which we can help reduce the burden of genetic diseases on families undergoing fertility therapy, or even just use it as a means to reduce disease risk for patients who are not having fertility discussions. So we're very excited to have Dr. Awadalla join us. And Michael, are you still connected? Hopefully I lost your picture there. Are you live? So waiting to see if Dr. Awadalla is joining us live. We may be having some connection issues. So while we're waiting to connect, let me just bring you guys up to speed a little bit with some of the outstanding work that JFF is doing. I've been lucky enough, I've been in practice here in Cincinnati since 1996 and working with some wonderful colleagues and our group at the Institute for Reproductive Health with Dr. Sharif Awadalla, Dr. Tom Burwinkle, now Dr. Michael Awadalla, as well as our wonderful lab staff and clinical staff, have all been building families for many generations. But we do realize that unfortunately, a lot of families have a financial burden that prevents them from pursuing the appropriate therapy that can really help them get pregnant and really overcome their fertility issues. And the community here in Cincinnati has recognized that, and we've partnered with the folks at JFF, with the Jewish Fertility Foundation, to really help provide some of the funding that's necessary for very deserving couples to be able to afford some of the treatments. Unfortunately, in Ohio, Kentucky, Indiana, these are not what we call mandated states, meaning that the insurance companies require fertility coverage for deserving patients. So it can be, unfortunately, a burden, despite the fact we're well below the national average for costs here in town. It can still be a burden for certain people to afford treatment. So in addition to the other programs here in Cincinnati who have also partnered with JFF, JFF is able to provide grants for people, financial assistance up to $5,000 to help with treatment costs. Most of the clinics are offering a 20% discount to members using the JFF grants to help those dollars go a little bit further. And there's also Jewish interest-free loans, so patients can borrow up to $7,500 completely interest-free through the JFF to help finance their fertility treatments as well. In addition to just the financial aspects, JFF also realizes that there's more involved with fertility therapy, and that it can create some stress for couples and or singles undergoing these types of treatments, and that emotional support is very important. So we have both virtual support groups twice a month, as well as a fantastic program called Fertility Buddies, which is super nice, where we pair you up with somebody who's been through these treatments before, whether that's an individual or another couple, to work with either you as an individual or couples together to sort of mentor them and just be a sounding wall and provide support from somebody who will kind of have some of these similar situations and knows what you're going through to help provide emotional support. In addition to that, JFF is also providing educational program through temple support and through various groups, public outreach, also helping to educate clinic staff such as our own, sort of what are the specific needs for, some of our Jewish patients in terms of halakhic requirements for fertility and what some of the, religious contingency can bring in terms of navigating the infertility journey in such a way that it can be ethically and socially comfortable for these patients. So they're doing an absolutely super job. We urge you guys to support them. And in fact, we've been lucky here in Cincinnati. The original JFF opened in Atlanta with a large group. We were the second group, and I've been in there since the beginning. I'm on the advisory council here for the Cincinnati JFF, but also I'm a medical advisor for the national JFF. And over the last few months, JFS has expanded not only through Atlanta and Cincinnati, but now with offices in Birmingham and Tampa as well. So, expanding across the country to provide these wonderful services to our larger family, to the members of the tribe and patients going through these fertility treatments. So I'm going to pop on my Zoom one more time here and take a look and see, is Michael ready? Is he able to join us live?
I think he says yes, right? If we've got the connection.
If you're hearing an echo,
setting it up.
I'm on Zoom.
Instagram again.
Super. So let's try and do that and see if we can bring him back.
There should also be a
right,
there we go.
Might be able to.
Great.
Also, you're muted, Dr. Awadalla.
Excellent. So it looks like I've been joined by my wonderful partner, Dr. Michael Awadalla here. We were thrilled to have him join us out of his training in California. And he did grow up here locally as well. Many of you may know some of his family members as well. And I will let him introduce himself a little bit and tell you about his experience and what drew him here back to Cincinnati and to join IRH. And then most importantly, he's going to spend just a few minutes talking about genetic screening and expanded carrier screening and how that allows us to segue into pre-implantation genetic testing to really help us achieve the healthiest outcomes possible for our patients. So Michael, thanks for joining us. Thanks for your support of JFF, and take it away.
Definitely. You can hear me all right?
I can hear you fine, and I'm hoping the rest of our audience can too. I'm going to mute myself for now.
All right. So I'm Dr. Michael Awadalla. I just joined Institute for Reproductive Health about 6 months ago, and I completed my training out in Los Angeles. So I'm going to talk a little bit about expanded carrier screening. It's kind of interesting. Expanded carrier screening actually started primarily in the Jewish community about 50 years ago. And there's two conditions that are the most important to screen for, and that's cystic fibrosis and spinal muscular atrophy. So with expanded carrier screening, it's actually kind of interesting because there's some conditions that tend to run in families, and typically these are conditions where just one defective gene can cause issues, and those tend to affect multiple family members. Expanded carrier screening is looking for issues where two defective genes cause the issue, and these are called autosomal recessive. The other ones where just one defective gene causes a problem are called autosomal dominant. So with the autosomal recessive, they tend to be new conditions that someone would not have a family history of, and then they show up in the offspring when a new couple starts having children. There's a few different ways to do the screening. You can screen for the most common two conditions. You can also screen for things that affect you based on ethnicity. And you can also choose a panel such as 30 conditions or 100 or 200 conditions to test for. Some of the newer data actually shows that even if you just screen for conditions that you're at risk for because of your ethnicity, you might be missing up to 50% of the genetic conditions. So probably using a panel that looks for 30 or 100 genes is beneficial. You can actually do the carrier screening anytime on your fertility journey. Most often couples will do it before they get started and decide if they want to have the screening or not to have it. The new thing with the screening is the cost has come down a lot. For most screening tests, both couples can get tested for under $500. And typically for Jewish Fertility Foundation, the testing is done before, right at the beginning. If couples are positive for the same condition, that actually happens about 1 in 30 of the couples. So most of the time we're looking for something that is not a problem, but 1 in 30, you can detect a condition that might actually cause a condition in a child. For couples that are considering in vitro fertilization, if there's a match on the carrier screening, we can actually test the embryos for that. So create embryos, take a small piece of the embryo that would become the placenta, and find embryos that'll be at low risk for having those conditions. Sometimes with the screening, there's some issues that we detect that are unexpected. So specifically, some of the conditions, even if you have one copy, you could be at risk for other health conditions. There's about 10 genes on most panels that may have some personal risk if you have one copy, so that's kind of important. Also, sometimes if you're positive for 1 or 2 genes, you might try and talk to your family members and see if they need to get tested as well. So sometimes these are things we talked about before the test is run, and sometimes they're considerations that we discuss based on unexpected results. Sometimes you can have some changes in your genes that have undetermined significance. So that's a consideration too. One of the other reasons to get the testing is that some of these conditions can show up on newborn screen. So it's much better to have the information beforehand than to have your newborn baby and find out on state screening that they are positive for a genetic condition that could have been detected before conception. So really, a lot of our patients are having the screening. Probably about half of our patients will get the screening and half will decide that they don't want to. And usually the ones that don't get the screening are planning on doing intrauterine insemination or other options. Usually the patients who are having IVF anyways would try and get the screening to have that information. So that's all I have to discuss. If you have any questions, you can put them in the chat and we'll go ahead and get to them.
Michael, maybe you can touch on some more interesting information. That was really wonderful. Thanks so much for updating us with that. Can you explain a little bit, in addition to testing for specific recessive diseases that we may find through the comprehensive genetic prenatal screening panels, can you also discuss a little bit how that same technology and the same biopsy techniques for the embryos can help us detect larger chromosomal issues and potentially help us select healthier, genetically normal embryos to put back, not only for specific diseases that are common in, say, the Ashkenazi population, like cystic fibrosis or Gaucher's or Tay-Sachs disease, but the actual overall chromosomal picture for those embryos as well.
That's a really good point. So for embryo testing, one of the most common reasons embryos are tested is not actually for specific genes, but for number of chromosomes. So the one example that I think most of us are familiar with is Down syndrome, which is an extra chromosome 21. So a lot of those embryos may become a miscarriage, and that's one of the conditions where it can actually progress to a live birth. Oftentimes, one of the reasons embryos don't implant is they could have an extra chromosome or too few chromosomes of any of the 23 chromosomes. And if it's not a chromosome 21 or several other conditions which actually can progress through a pregnancy, oftentimes those embryos won't implant, or they may only grow for a couple weeks and then become an early miscarriage. So one of the benefits to screening embryos for a number of chromosomes is that it decreases the number of embryo transfers a couple will need, helps them to get pregnant faster. So typically an embryo might have a 30 or 40% chance of becoming a live birth. If it's had the genetic testing done and it's normal, then it's actually about a 50 to 60% chance of a pregnancy and live birth for a normal embryo. So typically patients who are in their late 30s or early 40s would be the best patients to have the genetic testing for a number of chromosomes. And that's called aneuploidy, or pre-implantation genetic testing for aneuploidy. Patients who are in their 20s and early 30s, most of their embryos will be normal anyways, so they don't have as much to benefit from that screening, but it certainly is something that we can offer to those patients. So while the aneuploidy testing is the most common, testing for specific gene mutations is something we're doing more and more.
That's great. And I think one other thing to point out, of course, is unfortunately a lot of our patients suffer from recurrent pregnancy loss as well. And for patients, especially as you mentioned in that 38 to 42-year-old age range, where miscarriage rates may be 40% or higher due to abnormal chromosomal issues with the embryos, knowing that those embryos are normal going in can not only improve their implantation rates, as you just suggested, but many times their miscarriage rates might fall from 35 or 40% down closer to the 11 to 15% range. So both an increase in implantation and a reduction in miscarriage rate for those patients as well. So it's super exciting technology. When we started doing this, I did my first embryo transfers back in 1994. The thought that we would be testing embryos and actually being able to eliminate some diseases like sickle cell anemia or cystic fibrosis or Tay-Sachs disease, from families completely was just mind-boggling. And this technology has grown so fast and become so good. It's just a really exciting time to be participating in this. Of course, we can't do these technologies and treat these technologies unless we know ahead of time that patients do carry the genes for these recessive diseases. And that's why the comprehensive prenatal screening is so important. And in fact, patients, as you mentioned, Michael, that patients that are undergoing IVF treatments with financial assistance from JFF actually do all get what's called the J screen, which was the one you initially mentioned from way back when, doing a comprehensive genetic panel. So JFF was ahead of the curve already on this in terms of encouraging their patients to all be screened prior to starting treatment. So wonderful information. I think that's outstanding. I'm going to leave it here, Michael, to see if you have any questions that have come up in your comment section. Turn it over to hopefully all of our audience is participating, and send us your questions now. It's a great opportunity to tap into some Dr. Awadalla's young and strong mind to get some good advice. And I'll mute myself again, and we are thankful for our partnership along with those of the other practices here in town partnering with JFF, and for the efforts of JFF on behalf of all of our patients. So again, Hanukkah Sameach, and let's turn this over to some questions from our RG audience here.
I haven't seen any questions in the chat just yet, but while we're waiting for those, I also just wanted to mention the reason that I wanted to choose this topic to discuss is that it's a really expanding concept. It's really easy testing to get. It's available with a blood sample or saliva sample. Some companies will even send those test kits to patient homes with the order from a physician's office. And one of the newer things over the past few years is just the cost has come way down. I really think it's really beneficial to a lot of our patients, and with getting both partners screened for under $500, it's it just has such a benefit in preventing these. Some of these can be lifelong conditions. So it's sometimes patients ask us, what can I do to make sure I have a healthy pregnancy and baby? And the expanded carrier screening, I think, is at the top of my list for having a healthy child. So I think it's really beneficial, and it makes a lot of sense. And the technology has just come such a long way in the past couple decades.
Couldn't agree more. Very outstanding points, Michael. Thank you. It looks like there are some questions coming in on the monitor down there. So, Michael, are you able to see those, and can I turn those over to you?
I'm not seeing them on my screen. I don't know if they're just coming since you're hosting.
Great. Let me pop some of these up for you, and we can jointly address these. So thank you for sending these questions in. Here's one that says, if someone has multiple embryo transfers that are not successful, what other tests might be done outside of genetic screening of the embryos? So I think that's an excellent question, and obviously there's a lot of different factors that go into embryos successfully implanting and creating a healthy pregnancy. So certainly, as we mentioned and we've been discussing, the health of the embryo is certainly one of them. But don't forget, there's other things besides the genetics that go into the embryo. There's sort of, if you will, called the mitochondria, which we kind of refer to as the battery cells. There's the way that the cell structure allows it to divide and grow and implant. There's the hatching of the embryo. And then, of course, very importantly, is the receptivity of the uterus and the maternal environment. So all of those things are typically checked out before going into an IVF cycle. So a woman's uterus will be, carefully examined to see if it's prepared properly for embryo transfer, with typically ultrasound testing, sometimes X-ray dye tests like an HSG, or ultrasound tests like a saline sonography can be done to check things. Many times we'll do some practice transfers so that we know exactly where in the uterus to place the embryo. That can be important. And then over the last couple of years, there's been some newer testing called ERA, or endometrial receptivity assay, where we can do sort of a mock cycle where we would typically give you the same types of hormones and the same monitoring we would do for an embryo transfer cycle. But on the day when we would normally transfer the embryo, rather than doing the embryo transfer, we might take a biopsy as just a small piece of tissue from the uterine lining, which we can then look at under the microscope and in the pathology lab and in the genetics lab to assess various markers that tell us, yes, this uterus is receptive, this is just the right day to be doing an embryo transfer, or no, this particular woman in this environment, she needs maybe a day less or a day more of progesterone therapy or a different type of protocol. This is especially productive with frozen embryo transfers, is usually the scenario that we're doing this testing. So while the data are early in terms of knowing how much of an impact that's going to have over the long run, that's certainly some other testing that we've been doing. And then there may be, for certain patients, more so typically with pregnancy losses and failed implantations, but there may be a role for evaluating autoimmune factors, blood clotting factors, in addition to the uterine factors from that standpoint. Michael, anything to add to that?
I think you pretty much covered it all. And the other thing too is that if a patient's had a pretty extensive workup, sometimes it really is just, it's kind of like if at first you don't succeed, try again. It can take 2, 3, or 4 embryo transfers. So sometimes if there's been a appropriate workup done, transferring another embryo, it may just be an embryo factor. So that's an option as well.
Yeah, outstanding point. I think along the lines, that's where, JFF can be so helpful, because, having your fertility buddy and your emotional support network to get you through that second or even third embryo transfer is a huge benefit. We do understand how stressful that is for our patients, and we understand how disappointing everything is. Boy, when I started doing this, and pregnancy rates were, in our good patients, were 22%, 25%, and that kind of thing, everybody had 3 or 4 transfers, and it was sort of the expected norm. Now that IVF has gotten so good, and in our younger patients, more than half of them are conceiving with just 1 embryo with 1 try, the expectations are much higher and much different. But Michael's absolutely right that, in this game, patience really pays off, and just hanging in there a lot of times, even though it's not super satisfactory from a emotional standpoint, definitely can really pay off in the long run for you. So that's great. We have another question coming in through regarding the cost of IVF in Cincinnati versus Louisville. So I would say the main thing to say there is, IRH, we do have an office in Louisville. So right now, the majority of cycles being done in Louisville are being done through IRH. So it's exactly the same price as Cincinnati. We are, again, JFF works with the programs in town, several of them, including ours, which, provides a 20% discount, as well as their grants. So that does provide a significant reduction in cost for the JFF patients. But even in general, Cincinnati, although unfortunately, IVF is expensive everywhere where it's not covered by insurance. And again, Ohio's behind the curve a little bit in offering patients the coverage that they need. But we are still definitely in the very bottom percentage of the country in terms of cost in Cincinnati, while still providing pregnancy and live birth rates in the very top part of the percentages around the nation. So even though it's expensive, it's almost an expensive bargain here in Cincinnati, Louisville. Our patients that come to see us from Lexington, West Virginia, Southern Indiana, Southern Michigan, but we do get a lot of patients that come up from Louisville or Lexington specifically because we are less expensive than some of the other competing programs in town. Especially true if you're able to partner with JFF to achieve some of those clinic discounts as well as the fertility funding grants. So thank you for that question as well. And I think some of those other ones are overlapping, and in effort to keep this to a reasonable time frame to allow you all to get home and enjoy lighting the menorah with your families. Unless Michael, you have anything to add, I think we can say thank you for your attention again. Hanukkah Sameach, and hope you and your family stay healthy and safe. And one last pitch, if again, from a purely health standpoint, completely non-political standpoint, if you've not been vaccinated, get vaccinated. The data is very clear that it's safe in pregnancy. It's safe for patients trying to conceive. The data is also very clear that unvaccinated patients have a much higher stillbirth rate and miscarriage rate should they, get infected during pregnancy, and that the boosters also are being recommended by the, fertility societies as well as the American College of OBGYN and the CDC. So we would encourage you all to keep up your vaccine efforts, especially with new strains on the horizon here. And thank you so much for your attention, and you guys have a very good evening. And Michael, thanks so much for your time and joining us. And JFF, thanks again for your support and continued partnership. Take care now.
Thank you. Bye.